Hello, everyone, and welcome. Today, we'll be diving into the complexities of liver infections, inflammation, and cirrhosis. This presentation is brought to you by Newton TV, your resource for smart studying. Our focus today is liver disease, a significant health concern worldwide. We'll explore the various causes, including hepatocellular injury, obstructive injury, and a combination of both. We'll also discuss common liver diseases like hepatitis and cirrhosis, highlighting their prevalence and underlying factors such as infection and alcoholism. Let's take a look at the liver's anatomy and its surrounding structures. As you can see, the liver is located in the right upper quadrant, RUQ, and is composed of hepatocytes, the functional cells of the liver. It receives blood supply from both the hepatic artery and the portal vein, which drains the GI tract. This diagram illustrates the intricate process of liver function. Bile, produced by the liver and stored in the gallbladder, plays a crucial role in digestion. Bile salts are reabsorbed in the ileum and recycled back to the liver, demonstrating the liver's efficient recycling system. The liver plays several vital roles in metabolism. In fat metabolism, bile emulsifies fats, which are then broken down and absorbed. The liver also synthesizes cholesterol. In protein metabolism, the liver synthesizes albumin and performs deamination, converting nitrogen to ammonia. Continuing our discussion on liver roles, let's consider carbohydrate metabolism, hematologic functions, and endocrine factors. The liver is involved in glycogenolysis, gluconeogenesis, and glycogen synthesis. It also synthesizes fibrinogen and coagulation factors, and responds to glucagon, showcasing its diverse functions. This diagram illustrates carbohydrate metabolism. Ingested carbohydrates are broken down into glucose, which is then absorbed into the blood. Some glucose goes to body cells, while some is stored in the liver as glycogen. During starvation, glycogen is broken down into glucose, and fats and muscle are broken down into amino acids and fatty acids to synthesize glucose in the liver. The liver also plays a crucial role in detoxification. It processes ingested substances and drugs, with the portal vein delivering venous drainage from the GI tract. Additionally, the liver stores vitamins, iron, and copper, produces insulin-like growth factor 1, and synthesizes thrombopoietin for platelet synthesis. Here's a detailed view of the portal vein and its tributaries. The portal vein is responsible for carrying blood from the digestive organs to the liver, ensuring that nutrients and toxins are processed before entering systemic circulation. Understanding this anatomy is crucial for comprehending liver function and disease. This diagram shows a liver lobule, highlighting the hepatocytes and their arrangement around a central vein. The sinusoids, bile duct, and branches of the hepatic artery and portal vein form the portal triad. Hepatocytes are the functional cells of the liver, responsible for many of its vital functions. Hepatocyte injury can significantly disrupt liver function. This slide outlines the consequences, including decreased clotting factor synthesis, decreased albumin production, and impaired detoxification activity. This can lead to excess accumulation of drugs, hormones, and metabolites, as well as decreased storage of nutrients and impaired bilirubin conjugation. Bilirubin is a yellow-colored compound produced from the breakdown of red blood cells. This slide details the steps of bilirubin metabolism, from hemoglobin breakdown to the excretion of urobilinogen in urine. Understanding this process is essential for diagnosing and managing liver disorders. This diagram illustrates bilirubin conjugation. Unconjugated bilirubin, also known as indirect bilirubin, is converted to conjugated bilirubin, also known as direct bilirubin, in the liver. This process is crucial for bilirubin excretion and preventing jaundice. Hepatocytes can be affected by inflammation, hepatitis viruses, and toxic substances. Inflammation can be caused by viruses, drugs, or toxins. Hepatitis viruses like CMV and Epstein-Barr can also cause inflammation, and viral hepatitis may become chronic, increasing the risk for hepatocellular cancer. Toxic hepatitis can result from exposure to drugs like acetaminophen, which are processed by the cytochrome P450 system. Other conditions affecting hepatocytes include alcohol damage, non-alcoholic fatty liver disease, NAFLD, and non-alcoholic steatohepatitis, NASH. NAFLD can lead to fatty buildup in the liver and cirrhosis, while severe hepatocellular injury can lead to hepatic encephalopathy. Excess bilirubin can lead to jaundice, characterized by yellowing of the skin and sclera. Hyperbilirubinemia, or high bilirubin levels in the blood, is a key symptom of liver disease. This can be caused by excessive RBC hemolysis, hepatocellular injury, or bile duct obstruction. This diagram explains the different types of jaundice: prehepatic, intrahepatic, and posthepatic. Prehepatic jaundice is caused by excessive RBC breakdown. Intrahepatic jaundice is due to liver damage, and posthepatic jaundice is caused by bile duct obstruction. Bile duct obstruction can occur due to gallstones or tumors, blocking the flow of bile from the liver to the intestines. This leads to a backup of conjugated bilirubin, known as cholestasis, resulting in hyperbilirubinemia. Here are some clinical signs and symptoms associated with liver pathology. Spider angiomas and caput medusae are visible signs of liver disease. Other symptoms include changes in appetite, abdominal pain, jaundice, pruritus, acute tenderness, hepatomegaly, hyperbilirubinemia, ascites, and steatorrhea. Various tests are used to diagnose liver disorders. These include liver enzyme tests, ALT, AST, alkaline phosphatase, direct and indirect bilirubin levels, albumin level, prothrombin level, hepatitis serology panel, ultrasound, CT scan, MRI, and liver biopsy. Treatment options for liver disease vary depending on the cause and severity. Supportive care includes rest, fluids, and small, high-calorie, high-protein meals. Avoiding alcohol and non-prescribed drugs is crucial. Hepatitis treatment may involve interferon, nucleoside analogs, protease inhibitors, and other antiviral agents. Monitoring coagulation parameters, CBC, and metabolic panel is essential, and liver transplantation may be necessary in severe cases. Hepatitis is a common liver disease with various types, including hepatitis A, B, C, D, and E. Non-viral hepatitis can result from exposure to toxic chemicals, certain drugs, or autoimmune disease. Other hepatitis viruses include cytomegalovirus, CMV, and Epstein-Barr. General symptoms of hepatitis include fever, abdominal pain, flu-like symptoms, nausea and vomiting, fatigue, malaise, myalgias, arthralgias, and mild headache. Other symptoms include anorexia, loss of taste for food, hepatomegaly, jaundice, pale stools, dark urine, and pruritus. Hepatitis A is transmitted by the fecal-oral route. The virus is shed in feces and killed by thorough cooking. It causes fever, abdominal pain, and mild flu-like symptoms. A vaccine is available, and it is endemic in Asia, Africa, Mexico, and South America. Treatment is supportive. Hepatitis B is transmitted through blood products, body fluids, or sexual contact. It does not directly kill cells, but the host's immune system destroys viral infected cells. Hepatitis surface antigen, HBsAg, HBcAg, and HBeAg are important markers for diagnosis and monitoring. The stages of hepatitis B include an incubation period with no signs or symptoms, but the ability to infect others, lasting 2 to 4 weeks. The second stage involves an inflammatory reaction of hepatocytes, flu-like symptoms, and jaundice, with detectable HbAg, HbZag, and HbV DNA in the bloodstream and increased liver enzymes lasting 3 to 4 weeks. Stage 3 of hepatitis B is characterized by an immune system reaction to HbV, slowed viral replication, lower or undetectable HbV DNA levels, and liver enzyme levels decreasing to normal. Stage 4 involves the virus being undetectable, the presence of antibodies to HbSAg, HbSAg, and HbEAg, with antibodies against HbSAg, conferring long-term protective immunity. This timeline illustrates the levels of different antibodies and antigens over time in weeks after exposure to hepatitis B. It shows the levels of HbSAg, IgM anti-HBC, IgG anti-HBC, and anti-HbsAg, as well as the periods of jaundice and elevated liver enzymes. Signs and symptoms of hepatitis B include anorexia, nausea and vomiting, fatigue, flu-like symptoms, jaundice, hepatomegaly, splenomegaly, lymphadenopathy, spider angioma, and palmar erythema. Severe cases may show signs of hepatic encephalopathy, such as somnolence, confusion, stupor, or coma. Diagnosis of hepatitis B involves the presence of HbSAg in the bloodstream. Levels do not correlate with disease severity. IgM-type anti-HBC antibodies indicate acute infection, while IgG-type anti-HBC antibodies indicate chronic infection. Treatment for hepatitis B is based on symptoms and includes supportive care with rest and small high-calorie and high-protein meals. Interferon alpha may be used. Prevention is key. The course is variable and most do not recover completely. Chronic HBV can lead to hepatocellular cancer. Contacts can obtain HbIg for rapid passive immunity. Hepatitis C acute infection is usually mild, but most patients develop chronic hepatitis. It can remain dormant for years before symptoms appear, with a long incubation period of 2 weeks to 8 months. The patient is asymptomatic but can spread the virus. It is transmitted via blood, particularly through IV drug use. HCV RNA can be detected weeks to months before antibody development. The virus mutates rapidly, and there is no vaccination available. Hepatitis C treatment involves antiviral drugs. Current drug therapy aims for non-detectable levels of the virus in 12 weeks. Protease inhibitor combinations, such as paritaprevir, ritonavir, ombitacivir-based regimens, are used. Hepatitis D requires a helper function of hepatitis B and is transmitted through IV drug use or sexual contact. Hepatitis E is similar to hepatitis A and is transmitted through the fecal-oral route. This table summarizes the different types of hepatitis, including their source, route of transmission, whether they cause chronic infection, and prevention methods. This medical chart provides a comprehensive overview of hepatitis, including transmission methods, vaccine availability, common symptoms, treatment options, and diagnostic methods for each type. NAFLD, non-alcoholic fatty liver disease, is the most common cause of chronic liver disease in the United States. Its etiology is unclear, but associated with metabolic syndrome, insulin resistance, and obesity. Hepatocytes accumulate triglycerides, with steatosis defined as greater than 5% of the liver containing fat. NASH, non-alcoholic steatohepatitis, is an extreme form of NAFLD in which scarring and inflammation of the liver occurs. In NAFLD, the accumulation of fat disrupts cellular function. Cells can rupture, causing an inflammatory response that damages the liver. Mild cases may have no symptoms, but abnormal liver enzyme levels may be present. NASH can present with obvious signs of liver impairment, such as edema, jaundice, and fatigue. It can lead to hepatocellular carcinoma, HCC. There are no specific biomarkers or blood tests for NAFLD. Liver biopsy is a key test, but can give false negatives if the sample is not taken from a high fat content area. Patients who are obese have metabolic syndrome with elevated liver enzymes should be evaluated for NAFLD. The NAFLD fibrosis score is based on age, hyperglycemia, body mass index, BMI, platelet count, albumin level, and ratio of AST to ALT. NAFLD treatments include weight loss and exercise, bariatric surgery, and medication. Lipid-lowering agents should be monitored for liver toxicity, and insulin sensitivity medications may be used. Alcoholic liver disease includes alcoholic hepatitis, an acute disorder with reversible symptoms that resolves with cessation of alcohol ingestion, often leaving long-term effects. Alcoholic liver disease, also known as alcoholic cirrhosis, develops over a long period of time and is permanent, diagnosed with a liver biopsy. This slide highlights the impact of alcohol intake on liver health. It shows the different levels of alcohol consumption that can lead to cirrhosis in men and women, emphasizing the increased risk of developing alcoholic liver disease with higher alcohol intake. Alcohol is a potent toxin to hepatocytes. Hepatocytes can regenerate but are susceptible to repeated damage. Steatosis is the initial cellular change and can progress to cirrhosis. It is common for patients to not provide an accurate history of alcohol intake. Symptoms of acute alcoholic hepatitis include RUQ, pain and tenderness, nausea, malaise, low-grade fever, jaundice, darkened urine, and hepatomegaly. Severe alcoholic hepatitis can present with hepatic encephalopathy, coagulation dysfunction, spontaneous bruising and bleeding, hyperbilirubinemia, jaundice, and hematemesis. Hepatic encephalopathy, also known as portal systemic encephalopathy, PSE, is caused by increased blood ammonia levels, leading to changes in the level of consciousness, LOC, including progressive confusion, stupor, and impaired thinking and judgment. Neuromuscular disturbances such as asterixis, liver flap, and hyperreflexia are also symptoms. Treatment includes reducing protein in the diet and administering lactulose and neomycin. Chronic alcoholic liver disease presents with hepatomegaly and splenomegaly, portal hypertension with esophageal varices, ascites, spider angioma, proximal muscle wasting, gynecomastia in males, and withdrawal symptoms of restlessness, mood disturbance, tremors called delirium tremens, and possibly seizures. Alcoholic liver disease detection involves AST and ALT elevation, hypertriglyceridemia and hypercholesterolemia, hyperbilirubinemia and hypoalbuminemia, coagulation disturbances, and liver biopsy to confirm changes. Alcoholic liver disease treatment includes cessation of alcohol, proper nutrition, a high-protein diet, unless hepatic encephalopathy is present, and improvement of liver function if there is 6 months of abstinence from alcohol. Cirrhosis is a silent and gradual process where the liver is irreversibly damaged with collagen and connective tissue infiltration. Causes include hepatitis C, alcoholic liver disease, and NAFLD. Portal hypertension develops, leading to caput medusa. Liver functions are compromised. This illustration depicts the later clinical manifestations of cirrhosis, including jaundice, esophageal varices, ascites, hepatomegaly, splenomegaly, hemorrhoids, edema, changes in mental responsiveness and memory, spider angiomas, anemia, thrombocytopenia, coagulation disorders, collateral veins visible on the abdominal wall, palmar erythema, sexual characteristics changes, and peripheral neuropathy. This diagram illustrates portal hypertension, a complication of cirrhosis. It shows the liver, esophagus, spleen, splenic vein, inferior mesenteric vein, and inferior vena cava, highlighting the increased pressure in the portal venous system. Liver failure complications include portal hypertension, leading to esophageal varices, hematemesis, and ascites. Decreased bile synthesis results in decreased fat digestion and steatorrhea. Decreased coagulation factors lead to bruising and bleeding. Liver failure complications arise from decreased albumin synthesis, lack of thrombopoietin, decreased conjugation of bilirubin, and loss of detoxification process. These lead to edema, low platelets, jaundice, and high levels of drugs and hormones. This diagram shows a hand exhibiting liver flap, also known as asterixis, a flapping tremor. Complications associated with liver failure include loss of deamination process, high nitrogen in blood, anemia and thrombocytopenia, decreased fat-soluble vitamins absorbed, hypocalcemia, hepatic encephalopathy, and hepatorenal syndrome. This diagram illustrates the effects of liver failure on the human body, including encephalopathy, esophageal varices, hemorrhoids, anemia, thrombocytopenia, hyperbilirubinemia, jaundice, edema, bleeding, bruising, steatorrhea, medication toxicity, decreased absorption of fat-soluble vitamins, decreased calcium absorption, and lack of clotting. Cirrhosis detection and treatment involves blood tests including CBC, metabolic panel, and liver panel for diagnosis. Treatment includes abstinence from alcohol, good nutrition, and management of complications. Biliary cirrhosis involves dysfunctional bile. Primary biliary cirrhosis has an unknown cause, including inflammation and destruction of bile ducts, with a possible autoimmune component, and progresses through 4 stages. Secondary biliary cirrhosis is due to another disorder. Early stages are usually asymptomatic. It is more common in women in their 5th to 6th decade of life. Jaundice and steatorrhea may develop. Diagnosis includes elevation in liver enzymes, with elevation in IgM and antimitochondrial antibodies, AMAs. Treatment includes ursodiol, which reduces serum alkaline phosphatase and aminotransferase. Thank you for watching this presentation on liver infections, inflammation, and cirrhosis. Please subscribe, like, comment, and share this video to help others study smart with Newton TV.